All right, if you're a medical trainee, you are going to see a ton of irritable bowel syndrome. I mean, it's one of the most common things you'll see, whether you're in a primary care clinic or doing a GI rotation. So today, we're going to build a really clear, practical framework to help you manage it, and manage it well, right from the get-go.
So, why is this so important to get a handle on? Well, because a staggering 10 to 15% of adults are walking around with symptoms of IBS. Think about that. That means a huge chunk of your patient panel for the rest of your career is going to be looking to you for real answers. So yeah, mastering this isn't just a nice-to-have, it's absolutely essential. And this gets to the absolute core of how we understand IBS today. It is not just a gut problem. The best way to think about it is like there's static on the hotline between the brain and the digestive system. They're just not communicating right. And that idea is so fundamental because it shapes our entire approach to treatment. We have to treat the whole system, not just the symptoms in the gut. So here's our game plan. We'll kick things off with why IBS can be such a challenge. Then we'll walk through the essential first steps, getting the diagnosis right and figuring out the subtype. From there, we'll cover the foundational stuff that every single patient needs, and then we'll get into the specific medications. We'll also talk about what to do with those really tough cases, and we'll wrap up with what might be the most important piece of all, the partnership you build with your patient.
Okay, so let's just lock in the central idea one more time. IBS is complex. The pain, the bloating, the weird bowel habits your patient is feeling, that's all the end result of that bad connection between the brain and the gut. And that means our treatment has to be smarter. We can't just throw things at the gut. We have to address that whole brain-gut system.
All right, let's get into your clinical workflow. Step 1. Once you've made a positive diagnosis of IBS, you're probably using the Rome 4 criteria for that, the very next thing you have to do is figure out the patient's specific subtype. This right here is the key that unlocks the entire treatment path.
And this is the exact question you're going to ask yourself. The patient's sitting right there, you've given them a diagnosis, and they're looking at you thinking, okay, doc, what's next? Your next move is subtyping. And to do that, you need a tool, a way to turn their story into something you can actually work with.
And here it is, the Bristol Stool Form Scale. Honestly, this simple little chart is a total game changer in the clinic. It's your secret weapon for turning a vague complaint like, my bowels are just off, into specific objective data. You'll have your patient keep a stool diary for a week or two and use this chart to classify what's going on. That data is pure gold for what comes next. Because that data from the Bristol chart plugs directly into one of these 4 subtypes. It's simple math. If more than a quarter of their symptomatic days are constipation types, you've got IBS-C. If it's the diarrhea types, it's IBS-D. A mix of both, IBS-M. And this isn't just academic box checking. This is going to dictate your entire medication strategy. Getting this right from the start is absolutely crucial. Now, before we even think about medications, we have to build the foundation. There's a whole set of therapies that apply to every single person with IBS, no matter what their subtype is. And this is where lasting, effective management really begins.
I want to pause on this for a second because this is the bedrock. It's everything. IBS is a chronic condition. There's no quick fix. So taking the time to validate what your patient is going through, to build trust, and to set realistic goals together, that's not a soft skill. That is the first and maybe the most important therapeutic intervention you will make.
Next up are lifestyle changes, and these things are powerful. We know that regular physical activity improves symptoms. It helps with stress, helps with gut motility. Sleep is non-negotiable. Poor sleep literally lowers your pain threshold, which makes all the IBS symptoms feel way worse. And don't forget about brain-gut therapies, things like CBT or gut-directed hypnotherapy. These directly target that faulty brain-gut communication we talked about, and they can be incredibly effective.
Diet is a huge lever we can pull. For most people, we start with a first-line approach that's pretty practical. We're talking smaller, more frequent meals, maybe adding in some soluble fiber like psyllium, and avoiding the really common triggers like caffeine, alcohol, or super fatty foods. Now, for patients who try that and it's just not cutting it, we can then escalate to the low FODMAP diet. It's more restrictive, for sure, and it's best to do it with a dietitian, but man, it can be a game changer.
And if you do go the low FODMAP route, it's a very clear 3-step process. Don't let it be intimidating. First, there's a short-term elimination phase, usually 4 to 6 weeks. Second, and this is key, you systematically reintroduce foods to figure out exactly which ones are the triggers. And finally, the goal is personalization, creating a sustainable, long-term diet that's as varied and enjoyable as possible for that specific patient.
So you've built a great relationship, you've worked on lifestyle, you've dialed in the diet. For a lot of patients, that might be enough. But for those who are still struggling with symptoms, now we turn to medications. And our choice of what to use is guided completely by that subtype we figured out earlier.
First up, let's tackle IBS-C. Our goal here is pretty straightforward. We want to improve bowel movements, but without making the pain and bloating that often tag along with constipation any worse.
So here's our treatment ladder for IBS-C. We always start with polyethylene glycol, or PEG. It's over-the-counter, it's effective for constipation, though it doesn't do a whole lot for pain. If that's not cutting it, we step up to second-line agents like linaclotide. These drugs basically pull more water into the gut to soften stool, and they can also help with abdominal pain. Lubiprostone and tenapanor are further down the line, reserved for cases that don't respond to those first two steps.
Okay, let's pivot and talk about the other side of the spectrum, IBS-D. Here, the main goals are to get that stool frequency and urgency under control.
The ladder for IBS-D starts with loperamide, which is great for just slowing things down in the gut. If that's not enough, bile acid sequestrants are a good next move because a subset of these patients actually have a problem with bile acid absorption. Still struggling? A 2-week course of rifaximin, which is a special antibiotic that stays in the gut, can work wonders by tweaking the microbiome. And then for very severe cases in women, there's allocetrone, a potent drug that comes with some special monitoring.
Okay, so you've followed the playbook, you've tried these things, but your patient just isn't getting better. This section is all about 2 critical things. What do you do next? And even more importantly, when do you need to be seriously concerned?
This is one of the single most important questions you have to keep asking yourself when you're managing someone with what you think is IBS. Because remember, not all gut symptoms are IBS, and your #1 job as a clinician is to know when to stop and dig a little deeper.
And this slide right here, you need to burn this into your memory. These are the alarm features, the red flags. If your patient mentions any of these things, like losing weight without trying, being woken up from sleep by diarrhea, or brand new symptoms after age 45, you have to hit the brakes. That is a signal that this might not be straightforward IBS. These demand a prompt referral to GI for a more thorough workup. Do not wait on these.
We have covered a lot of ground, from diagnosis all the way to advanced therapies. But I want to bring it all back home, circling back to the single most important theme in managing this chronic condition.
Please remember this. There is no magic bullet for IBS. There just isn't. Success comes from a long-term partnership with your patient, where you work together, tweaking and combining lifestyle changes, diet, and targeted medications. It's a journey, not a destination, and you're going to be their guide on that journey.
And I'll just leave you with this final thought. The science behind that brain-gut axis is exploding right now. We've gone from thinking IBS was all in your head to truly understanding its complex neurobiology. So the real question for your generation of clinicians is, what comes next? You are entering medicine at this incredible time when we're just beginning to unravel these connections. What new pathways, what new treatments will you help discover? The future of IBS care is truly in your hands.